Hello, this is Dr. Amy Beltwell. I am the co-principal investigator of the Agency for Healthcare Research and Quality's Reducing Medicaid Readmissions project. I'm pleased to welcome you to the second webinar in a six-part webinar series to support the dissemination of the Hospital Guide to Reducing Medicaid Readmissions, Designing and Delivering Whole Person Transitional Care. This is webinar 2, Analyze Data and Patient Caregiver Perspectives. And during this webinar, we will cover section 1 of the AHRQ framework. The agenda for this webinar is to describe Medicaid readmission patterns and how they're similar to and different from Medicare patterns you may be familiar with. We'd like to describe the 15-part data analysis we recommend in order to provide some new insight into all payer and payer-specific readmissions at your hospital, and to describe the patient and caregiver interview process to help your readmission reduction teams better understand readmissions from the patient and family caregiver perspective. The objectives of this webinar are the following. We hope that users of the guide will understand 3 ways in which Medicaid readmission patterns are similar to and 3 ways Medicaid readmission patterns are different from Medicare readmission patterns that you're already familiar with. We hope users will understand why eliciting the patient perspective is helpful for identifying opportunities for improvement and in designing effective strategies to meet the needs and root causes of readmissions at your hospital. And finally, to understand the tools available through the guide to support this work. The Hospital Guide to Reducing Medicaid Readmissions, as you'll remember, is presented to you according to the AHRQ framework. And here in webinar 2, we will talk about the A component of the AHRQ framework, Analyze Your Data. The tools we will cover are the first 2 tools in the guide, the data analysis and the readmission review tool. Just to remind you that the AHRQ framework is a 6-part set of recommendations designed to help your readmission reduction team engage in a data-informed strategic redesign of your readmission reduction efforts, as well as implement improvement work in each of 3 critical domains of action. So let's move into the all-payer and payer-specific readmission analyses that can provide some new insights into reducing readmissions for your organization. Question 1 is, why analyze your own data? Certainly hospitals have readmission data reports sent to them from a variety of sources, sometimes vendors, sometimes payers, and so why do we emphasize the importance of analyzing your own hospital's data? Your hospital-specific readmission patterns may differ in important ways from national patterns. This is especially true for high-volume Medicaid and other safety net organizations. So we'd like to encourage you to look at readmissions through a different lens and, of course, be informed by everything you've read in the national literature, but really look at your hospital, your patient population, look at readmission rates by payer, look at the top 10 diagnoses leading to the most readmissions at your hospital, setting aside what you think have been identified as priority conditions and looking really what are the priority conditions at your hospital. Look at the proportion of all readmissions at your hospital that have a comorbid behavioral health condition associated with that, and look at readmissions by discharge disposition. These are just a few ways that you and your readmission reduction team may or may not have looked at readmissions in your organization previously. So I'd like to walk you through a few set of data slides that will highlight all payer readmission analyses and payer-specific readmission analyses, and these are really intended to help you understand where this 15-point data analysis comes from and the insights we have observed that it can provide to readmission teams like your own. So the first slide here is from an all-payer statewide readmission analysis in Massachusetts, and what you're looking at here at the orange bar is the statewide all-cause adult readmission rate. And you can see in Massachusetts it's 15%. And for all Medicaid patients circled in the small blue square, you can see that all adult non-OB Medicaid patients had a higher rate of readmission than any other payer category in the state of Massachusetts. To be sure, it's very close to the Medicare readmission rate. In Massachusetts, the Medicare readmission rate was 17% and the Medicaid readmission rate was 17.5%. Not specifically different, but reminding us that Medicaid and Medicare populations are at higher than average risk of readmission, and that all commercially insured patients for whatever of any adult age and for any diagnosis have a much, much lower readmission rate as a population. The next graph we're looking at is readmissions by discharge disposition. And I find this to also be a very helpful way to differentiate groups of patients at different risk of readmission. So here in the top graphic, it's again from the statewide all-payer analysis in Massachusetts, and we can see here that of all patients discharged to home, their readmission rate was about 11%, again, any diagnosis, any payer, and all patients discharged to skilled nursing facility, home with home health care, or inpatient rehab have a markedly elevated risk of readmission as population groups. Again, any diagnosis, any payer. And so you can see that looking at discharge disposition can clearly help differentiate groups of patients at differing risk of readmission. Down here at the lower part of the slide, this is from a safety net hospital's readmission analysis, and what we're looking at is for this high volume Medicaid hospital, they looked at the percent of all Medicare patients discharged to home, to a skilled nursing environment, or home with home health care. And then they compared that to all Medicaid discharges to home, to a skilled nursing environment, or to home with home health care. And here you can see that their Medicare patterns probably very similar to other hospitals' Medicare patterns. About a little bit more than half of Medicare discharges were to home, and a little bit less than half of all Medicare discharges were into skilled nursing post-acute care settings. But for Medicaid, it was a very, very different pattern. And you can see the preponderance, almost 85% of all Medicaid adult discharges were to home, and a small fraction of Medicaid discharges were into post-acute care. So for many hospitals today focused on Medicare readmissions, we know that you have some very good and very effective and very important work going on with your post-acute skilled nursing and home health colleagues. This is important work, and you should continue to do it by all means. What we're encouraging you to recognize is what you implicitly already know, which is that working with post-acute providers and skilled nursing providers is a strategy that is going to predominantly benefit your Medicare readmission rates. And when we look to expand your work and adapt your strategies to better serve Medicaid patient populations, this data here would suggest, okay, we've got to think about the Medicaid population, they're being discharged to home, and so who are the providers and the services and supports that we can link to and better connect with because our Medicaid patients are being discharged to home, and partnerships with skilled nursing facilities not as high leverage for this particular patient population. Moving now into comparing and contrasting what many of us have become accustomed to thinking of with regard to readmission risk, which is discharge diagnosis. Now, discharge diagnosis is only one of a variety of ways of identifying patients who may be at high risk of readmission. But nonetheless, we can use this analysis, the statistical brief from the AHRQ's Healthcare Cost and Utilization Project, to look at how the top 10 discharge diagnoses for Medicare are similar to and are different from the top 10 discharge diagnoses for Medicaid that led to the most readmissions. So for Medicare, we see that heart failure, sepsis, pneumonia, COPD, and so on leave the top discharge diagnoses that result in the most readmissions for Medicare. When we compare that to the top discharge diagnoses that resulted in the most readmissions for Medicaid, we see that mood disorder, schizophrenia, diabetes, complications of pregnancy, alcohol-related, and other substance use disorders are on the top 10 list for Medicaid. So again, when we think about expanding and adapting our strategies to better serve the Medicaid population, we can use this type of a compare and contrast of discharge diagnoses to identify the ways in which certain high-frequency discharge diagnoses are similar, and then, of course, there are some discharge diagnoses that are different that compel us to move much more focused and strategically into addressing behavioral health and substance use disorders in particular. Graphic is from a Medicare statewide readmission analysis in Virginia, and thanks to the Virginia QIO. And why am I showing a Medicare readmission chart in a talk about Medicaid readmissions? It's to, again, emphasize how important it is to know your specific data and to cast aside the areas of focus that we have become accustomed to responding to because of various payer incentive programs, and to look at the data and to really see and consider what the data are showing us. And so I present to you this slide because, as you can very clearly see, these are the discharge diagnoses leading to the highest numbers of Medicare readmissions in Virginia. I've seen this pattern repeated across the country, so it's by no means unique to Virginia, but it's something that we are not accustomed to talking about, which is you can see that the #1 discharge diagnosis not only leading to the most readmissions for Medicare patients in Virginia is sepsis, and it is not by a small margin. You can see that there are over 3,000 readmissions following a discharge for sepsis in Virginia, and the next most highest ranking discharge diagnosis is acute kidney failure, another condition that we are not actively screening for, and that resulted in 1,500 readmissions, followed by #3 ranking in at pneumonia, heart failure, etc. And so what I encourage you to use this type of a table for, whether it's Medicare data, Medicaid data, or all payer data, is to really look at the data and to think, wow, did I know that? Are we focused here? Have we developed a response to address what the actual data are telling us? And this is an opportunity, hopefully, while you're taking the time to look at your all-payer and payer-specific data, really look at what it's telling you, not only for Medicaid, which is the focus of our work, but for all of your payer classes and your population overall. So turning now to an area of greatest focus in readmission reduction work is heart failure. And almost all hospitals have some sort of focus on reducing readmissions for heart failure this day and age. And so one thing that I love about this graph is it teaches us to look at all ages and all payers with regard to what we classically think of as an older adult Medicare readmission issue. So again, this analysis is courtesy of the Agency for Healthcare Research and Quality, and what we can see is in national data, we see that the younger heart failure patients actually have higher readmission rates, and that we also see that Medicaid heart failure patients have higher readmission rates than Medicare. So as we think even about a classic readmission condition such as heart failure, let's not be ageist and let's not focus only on one payer type. Clearly this is a population that needs better transitional care across ages and regardless of payer class. Finally, it's becoming increasingly common, and we recommend looking at readmissions for patients with a personal history of repeated hospital utilization. And this slide is a combination of two sources of data. One analysis that the Agency for Healthcare Research and Quality has done based on national discharge data, and another analysis that was the statewide all-payer readmission analysis in Massachusetts, which is where this graphic comes from. Both analyses used the cutoff of 4 or more hospitalizations in a 12-month period to define high utilizers. And what is really interesting is all high utilizers defined as 4 or more hospitalizations in a year have a 30-day readmission rate of 40%. 40%. And anyone who was hospitalized 1, 2, or even 3 times in the year has an aggregated readmission rate of 8%. So this is a cutoff and a threshold that really differentiates two very different groups of patients in the hospital. Surprisingly, I find 3/4 of high utilizers are discharged to home, suggesting that perhaps we're just repeating the same discharge disposition, or perhaps we have challenges accessing different types of post-acute care for these patients. And that the top discharge diagnoses leading to the most readmissions for high utilizers are a balance of behavioral health, chronic, and infectious disease diagnoses, such that there's not just one clear, of course, not one clear diagnosis that's leading, although you can very clearly see that behavioral health is a major component for this population, and that's substantiated by numerous other research findings in the literature. So here on the graphic, we can see that at least in Massachusetts, for patients who had 4 or more hospitalizations in a 12-month period, this was 7% of hospitalized patients in the state. Those 7% of patients used 25% of all admissions and accounted for 59% of all 30-day readmissions. So we have the opportunity, the message here from this slide is that as you take the opportunity to look at your own data and to reconsider how you're focusing your readmission reduction efforts, what patient populations you're focused on and why, this is a group of patients, of course, a small number of people, accounting for a very disproportionate number of readmissions, and is worthy of you considering whether or not their needs are being adequately addressed by your readmission reduction strategy. I'll remind you that this entire slide, all of this data is payer nonspecific. This is all payer high utilizers. So as a result of extensive field work over the past 5 years, we have come up with this 15-point data analytics plan that is feasible for hospital-based data, finance, or quality analysts. We have learned that it takes about a day's worth of work to do. So it does, of course, take someone sitting down and putting in some effort, but it's feasible with a day's worth of effort, and these 15 analytic queries can walk you through a series of findings, much like I've just walked you through in the prior slide, to help expand an understanding of readmission patterns at your hospital, to look at readmission risk groups in a slightly different way, and reconsider whether or not your current readmission reduction strategy is focusing on the groups of patients at your hospital with, in fact, the highest numbers or the highest rates of readmission. So this 15-point analytic plan has been turned into an Excel-based data analytic tool. Some people prefer the 15-point slide, and some teams prefer the live Excel document. The live Excel document allows your analysts to put in the results of the query, and based on the results of the query in the first tab, we've pre-populated some visuals, data visualization in subsequent tabs with some interpretation questions to help your team interpret the data and understand what you're seeing in the patterns. The second major task that we recommend in this analysis phase is to understand the patient and caregiver perspectives of readmission, to really elicit the story behind the chief complaint and identify all of the root causes of readmissions so as to not over-medicalize what people need in order to be safe and recuperate successfully in the post-hospital period. So we continue our recommendation that we had in version 1, and in fact that had been popularized by the Institute for Healthcare Improvement STAR initiative prior to that, to review readmissions from a whole person view. And when we interview patients and their family caregivers to understand the story behind the readmission event, this takes us well beyond a chart review and encourages us to really listen to what does the patient identify as the key events that occurred between the time of first discharge and the time of returning to the emergency room as creating roadblocks, barriers, challenges, or points of confusion in their post-hospital care period. So I'll share with you 2 readmission reviews that we have done over the years that are relevant to the Medicaid adult. The first readmission review was conducted on a 41-year-old woman who had known long-standing HIV, had previously been in care and followed up every quarter for years and years. Fortunately, her HIV had been stable for a number of years. So she had fallen out of care over time. She was hospitalized initially for pneumonia, started on HIV medications as well as antibiotics for her pneumonia, and instructed to follow up with her HIV and primary care provider. Unfortunately, she was readmitted 8 days later, and we interviewed her. The second story is a 61-year-old man who was met in March of last year, and at that time he had already had 8 hospitalizations that year, all for shortness of breath. And he was returning to the hospital 10 days following his prior discharge, again for shortness of breath, and it was at that point we interviewed him. The big recommendation here, or the salient addition to your readmission reduction analysis that these interviews offer, are here in a quote from a team that had not been doing these interviews and then started doing these interviews and found, quote, billing data aren't going to tell you whether a patient needed a pharmacy intervention, needed a place to live, or couldn't afford their medications. And so for as important as the Part 1 data analysis is, you must supplement your work with the patient perspective. So very briefly, the 41-year-old woman with longstanding HIV who was hospitalized with pneumonia. I told you about she was diagnosed with pneumonia, started on not only antibiotics, but HIV antiretrovirals, so new medications on a variety of fronts. They knew that she, quote, the team knew that the patient lived at home. But what they didn't know was that the mother was unaware of her HIV status. At discharge, the patient was discharged on new medications, which should have been a red flag, and she was told to follow up with her HIV doctor and with her primary care doctor, assuming that she had those physicians. Turns out she did not have an HIV doctor or a primary care doctor, and she got home, and in her living environment with family members unaware of her HIV status, she was not about to make phone calls, search the web, and otherwise reach out to establish care, which, as we all know, is not easy to do for anyone, let alone somebody who has sensitivity around their medical privacy. So when she was readmitted 8 days after discharge, the team went down and interviewed her, and she reported that she returned because she kept coughing, and the instructions said to return if her symptoms didn't improve. And she simply didn't know if at 8 days she should still be coughing or not. She wasn't acutely ill, she wasn't confused, she wasn't febrile. She needed what could be considered a straightforward medical evaluation that could have been done in the ambulatory care setting. She had a question that needed to be answered, and so she returned to the emergency room. When asked what would have been helpful, do you have any ideas about how we could have helped you not need to come back to the hospital so soon? This is a direct quote from her. It would have been helpful if they made the appointment for me. Recognizing the numerous ways in which making an appointment was an insurmountable barrier to this particular person in this particular circumstance. What I appreciate not only is the compelling person-centered nature of this story, but also when teams think about expanding their readmission reduction efforts to Medicaid patients and to younger middle-aged adults, patients with behavioral health, social complexities, maybe medical conditions that aren't as frequent in the Medicare population, teams often tell us that these patients are too complicated. And what I hope you might appreciate from this story is that this patient's circumstances were not too complicated. In fact, what she would have benefited from is something that many of us consider basic, thorough transitional care at this point, is to ensure providers are in place and to ensure that patients not only have appointments but can get to those appointments. And that's what she identified as something that would have been helpful for her, so she wouldn't have had to come back to that emergency room. So I hope you can remember this particular story as emblematic as a not overly complicated, avoidable readmission. The second gentleman is a little bit of a different story, and I've told this story to audiences across the country, and everybody knows a patient like this. This is a 61-year-old man who has already had 8 hospitalizations for shortness of breath. The first time he was presented to me on the, quote, first hospitalization, what I came to appreciate that the house officers did not appreciate was that although it was the first time we, as individual medical providers, were meeting him, by no means was this the patient's first presentation to this hospital or to any hospital. And so we need to remember that we are meeting somebody in a cycle of repeated hospitalizations, and yet often in the course of doing our medical evaluation and work in the hospital, we take each presentation as if it were de novo. And so part of the issue here is to identify a cycle of repeated hospital use and put it in context. We learned about the patient that he lives in a single room occupancy. He eats 1 meal a day when he's out on his own. He does have personality disorder issues, and he has a criminal history, which has complicated his ability to be placed in skilled nursing or long-term care environments. He's also refuses to work with physical therapy, which for someone who has breathlessness is part of his interdisciplinary plan of care in order to increase his exercise tolerance and his overall fitness. So although we knew all of these things about the patient, he was nonetheless discharged to, quote, home, and he was instructed to follow up with his primary care physician. In retrospect, we can see that a discharge to home is yet another discharge that goes into his environment that is probably not going to be a sustainable environment for him. Also, he's told to follow up with primary care, and if we cared to look, we could see that that has been his discharge plan for eight prior discharges, and yet he has not been to a primary care appointment in over a year. So again, putting the story of repeated hospital use in context allows us to really consider what have prior discharge plans been and to grapple with the failure of those prior discharge plans so that we can try to open up new avenues of opportunities to avoid readmissions for patients like this in the future. When I met him on the readmission, he had reported, but we didn't have documented, he had reported that he had gained 20 pounds in the 8 days since he had been gone, although it was hard to substantiate that. And when I asked him do you have any ideas about how we can help you stay out of the hospital? I'm sure you don't like to be here as much as you have been. He said to me, quote, "Oh, honey, I'm here a couple times a month, and it always takes him about a week to tune me up." And he grabbed the remote and turned on the TV and picked up his meal menu. And I remember from that interaction realizing that the patient likes being here. And so that opened up a line of thinking and root cause analysis that really helped us understand that this is not a patient who's devastated to return to the hospital. In fact, this patient seeks to return to the hospital. And thus, you can imagine, once you have that type of an insight, you might be able to put together strategies and approaches to address that particular root cause of readmission, which is extremely different from another type of root cause. So this approach has been repeated and substantiated across the country, and I'd like to share with you just two very nice publications, one from a Kaiser Permanente team and another from a North Philadelphia hospital emergency medicine team. The Kaiser Permanente team did readmission interviews on over 500 readmissions across 14 of their hospitals in Northern California. And a key finding in their readmission review process was to not look for the reason for readmission, as if one missed appointment made or one discharge disposition decision was the root cause of the readmission. The Kaiser Permanente team encourages us in their article to look for all of the factors that contribute to readmission, and I think that that is a very helpful concept. The Philadelphia team interviewed a case series of bounce backs to the emergency room, and what they found in people who had been seen in the emergency room and then came back soon thereafter, they found that the average age of these patients was younger, 43. The majority had a primary care physician, and the majority reported no specific problem in affording or filling or obtaining medication. And so this team found that there was a patient preference and a convenience to using the emergency room, all hours, high-tech care, more testing, more immediate answers, that was driving a preference-based decision to come back to the emergency room. And also, these patients were seeking an immediate answer or reassurance. And so the team found the following three bullets that I have on the screen here, which are the following. They found that the primary root cause for a quick return to the emergency room was fear and uncertainty about their condition. They were seeking reassurance from the provider that they were recovering on track, that there was no further need for concern, et cetera. And they concluded that patients needed more reassurance both during and after episodes of care, and they really needed access to advice between visits. So again, you may come up with your own root causes and your own interpretation, but you can see that interviewing serial groups of patients who are returning to your hospital can really help identify root causes and opportunities for improvement that may not be provided to you just through a pure data analysis. So we have worked to streamline and clarify the readmission review tool here in version 2. The purpose of the tool is to understand the patient perspective, understand root causes of readmission, to understand there are multiple factors that contribute to a readmission, identify opportunities for improvement overall for the system, as well as to develop a better plan for that individual patient moving forward. We recommend that the executive in charge of designing a multifaceted data-informed portfolio of strategies, we recommend that the executive champion conduct at least 5 interviews, and that having the experience of talking to patients and understanding what they do and do not understand about their experience of care, why they came back to the hospital, et cetera, is foundational for really setting a strategy in place that deals with the combination of clinical, behavioral, social, logistical factors that result in readmissions. So we recommend that the executive champion of readmission reduction work at the hospital has the direct experience of conducting readmission interviews, just a handful, and that we have observed that there's a best practice in hospitals across the country to review each and every single readmission, not only for the purposes of improving care for that patient directly, but for identifying continual opportunities for improvement for the system overall. I'd like to share with you one example of using data analysis to inform a different way of identifying patients at high risk of readmission. This is a high volume Medicaid hospital. And in 2014, this high volume Medicaid hospital proposed to a funding agency that they wanted to reduce readmissions by focusing on the, quote, Medicare penalty conditions. The funding agency encouraged this hospital, knowing that they were high volume Medicaid, to set aside the specific focus on heart failure, AMI, and pneumonia, and rather look at their data analysis, compare and contrast Medicare and Medicaid readmission and all-payer readmission conditions. Based on that analysis, this analysis that we recommend in the guide, the hospital came back to the funding agency and identified a target population that was a combination of patients with social complexity, as identified in the administrative data, or medical complexity, as identified in the administrative data. And so the elements that they could pick up at their particular hospital for social complexity were homelessness, any behavioral health comorbidity, including substance use, or a lack of a primary care physician. The elements that they picked up for medical complexity were the discharge diagnoses leading to the most readmissions at their hospital, which you can see not only included the heart failure, heart attack, and COPD and pneumonia, but expanded to include diabetes and sepsis. And again, this was from their direct analysis of their all-payer and Medicaid-specific data. Using this definition, they have been using this for the past year, and they find that fully 30% of all of their adult admissions to the hospital have either, quote, social complexity or, quote, medical complexity as defined here in their definitions. So 30% of their admissions are high risk, and the high risk group has a readmission rate of 25%, which is very nicely differentiated from all of the other not high risk admissions, which has a readmission rate of 10%. So you can see by using their own data, identifying patients in their administrative data who have social or clinical high-risk features, they have developed their own very effective stratification tool to identify not only a robustly sized target population, 30% of all discharges, but that 30% of all discharges has a readmission rate that's 2.5 times anyone else that doesn't meet those criteria. So this work has now prepared them this year to move into getting ready to participate in a Medicaid accountable care model, and they have taken the advice from this guide to consider all Medicaid patients at high risk of readmission as they seek to expand their work to reduce readmissions for their entire hospital. So this is an example of how we hope you will use your own data to identify your own target populations based on what you really see in the data, not just on what the market incentives around you are suggesting. So in summary, know your data, elicit the root causes of readmissions, and use this information to identify groups of patients with high readmission rates at your hospital, determine how to target your readmission reduction efforts, better understand why patients return to the hospital so soon after discharge, identify opportunities for improvement, and design strategies that will effectively address these patients' transitional care needs. So thank you for attending this second webinar in our 6-part webinar series, and thank you for your commitment to reducing readmissions. On behalf of my colleagues, Dr. Angel Burgoyne and Dr. Jim Maxwell at John Snow, I thank you for attending this webinar and have a great day.